Hey everybody, this is our chapter 37, Pediatric Solid Tumors. I will be covering many of the same things that we talked about in class that you guys had covered as well, and hopefully you will find this helpful in studying for your exam on Monday. The topics that we're going to cover are brain tumors, retinoblastoma, neuroblastoma, Wilms tumor, some soft tissue sarcomas, the section on miscellaneous childhood tumors, palliative radiation, and our role as radiation therapists. Now, childhood cancers, there are an estimated 10,500 new cases of childhood cancers each year between the ages of 0 and 4. Another 5,000 between the ages of 15 and 20. Acute leukemia and lymphomas account for about 40% of all pediatric cancers. Central nervous system tumors are the most frequent solid tumors found in children. Childhood cancers are very different from adult disease. The treatment differs in various ways. It's different because of the fact of the long-term effects of treatment, that the lifespan of the child is far greater than that of what is expected with an adult that has a malignancy. There's different psychosocial issues, body awareness of children at a younger age. Therefore, treatment is always multidisciplinary, requiring close attention to the physical and emotional needs, not only of the child, but of the family as a whole. And the statistic for patients that are involved in clinical trials are more than 50%. And most of these are going to be led by the Children's Oncology Group. Brain and spinal cord tumors are the second most common cancers in children. Leukemia, remember, is the number one cancer in children. Low-grade and infiltratorial or posterior fossa tumors are more frequently found in children as compared to adults. The late effects of children are really a large concern. Because of this, many individuals are involved in their cancer care. Most benign and malignant tumors are going to appear sporadically, and metastatic lesions are from non-CNS tumors to the brain are less common than primary tumors. Now, if you remember with adults, the most common brain lesion was metastatic disease, and that is not the same. It does not hold true for the children. For children, they're going to see more primary tumors than metastatic disease. Low-grade astrocytomas are the most common type of astrocytoma found in children. The tumors tend to resemble a normal glial cell, but continue to grow slowly. They will tend to show up more commonly in the posterior fossa and cerebrum. The patient usually has a history of long-term mild symptoms such as headaches, degenerating coordination, visual issues. Poor school performance is another symptom that's observed in these children. So they are going to develop slowly over a period of months and years. And eventually what will happen is the child will probably start having seizures, which lead the parents to investigate what's happening with their child. Radiologically, a cystic component can be found in these low-grade astrocytomas, but they are usually solid. These tumors have less edema than a high-grade lesion. If they're found in the very young child, in young children who don't display major neurologic defects, low-grade brain tumors can be followed without immediate treatment. And this is done mostly to allow for that brain to mature. Because if we would radiate or try to do surgical intervention on a young child, that's very difficult. So they will follow this child into ages of 3 to 5 when that brain is more mature. And that at this point, neurosurgery is going to be the primary treatment. So long-term prognosis for these low-grade astrocytomas is fairly high at 90 to 100% recurrence-free survival if that tumor is completely removed. There are some special types of astrocytomas that do hold a good prognosis. They are almost always associated with tuberous sclerosis. Tuberous sclerosis is an inherited condition which can also cause epilepsy, mental retardation, and tumors that are found on the skin and in the kidneys. The two types of special astrocytomas that I have listed here are, one is known as a juvenile pilocytic astrocytoma, and this tumor commonly occurs in the cerebellum, but also in the optic nerve, hypothalamus, and within the brain itself. The subependymal giant cell astrocytoma usually occurs in the ventricles, and it is almost always associated with that tuberous sclerosis. The role of radiation therapy is used for surgically inaccessible, recurrent lesions and post-surgical residual tumor. So target volumes will have about a 1 centimeter margin around that CTV plus an additional 0.5 centimeter for the PTV for 3D treatment planning. Obviously, the use of IMRT is going to help spare critical normal tissue better than any other method of radiation therapy. And radiation therapy does contribute to long-term control. However, progression of these tumors may occur years later. High-grade astrocytomas tend to grow rapidly. Then they will invade and destroy brain tissue and spreading through the CNS or evenly distantly. High-grade gliomas are usually supratentorially with neurologic symptoms that progress quickly. They are classified in order of escalating malignancy from going from an anaplastic astrocytoma to a glioblastoma multiforme. Symptoms of these tumors include headaches, lethargy, motor skills, sensory loss, seizures, altered mental status, and intracranial hemorrhage. Steroids are going to be given prior to surgery to reduce the edema of around that tumor, and staging has been proposed according to tumor size, ventricle or brainstem invasion, and metastasis, but is not routinely used. So they don't really use a staging system for these tumors. Radiologically, these lesions have very indistinct borders and areas of necrosis with surrounding edema. Neurosurgery is the first step that's going to yield a histologic diagnosis, removing gross tumor and decompressing the adjacent structures. Chemotherapy and radiation therapy are going to be used post-operatively. Temozolomide is the drug of choice. It's especially important to utilize chemotherapy in infants to delay the need for radiation therapy while that brain matures. And it's, usually there's going to be some residual tumor left behind after surgery. Radiation therapy for these high-grade astrocytomas are going to require a large target volume. 3D conformal or IMRT is generally the technique that's used. And the CTV volume includes gross residual tumor that's left after surgery. It includes a surgical bed and any surrounding edema. Further, a 2 centimeter margin is typically placed around that CTV with doses anywhere from 4,500 centigrade to 5,000 centigrade. Overall, the prognosis for the patient is poor because controlling these tumors locally is a major problem. Optic gliomas are next. Some argue that these tumors are actually benign, but optic tract and hypothalamic gliomas are considered one entity. They are usually low-grade astrocytomas. Visual disturbances is the most common presenting symptom. Children with neurofibromatosis are at a higher risk for these tumors. Neurofibromatosis is a genetic disorder that causes tumors to grow on nerve pathways, but they can be found anywhere in the body. So long-term follow-up for these kiddos is required. Primary chemotherapy may be tried in young children to delay radiation therapy. The use of MRI planning is actually very vital for treatment to get a good look at these tumors. Tumor volumes actually must account for potential spread. Doses between 5 to 5,400 are going to be used with the treatment fields. Proton therapy can be very helpful because of how proton therapy can be programmed to really stop at a certain depth within tissue. A 3D conformal, IMRT, again, are going to be treatments of choice as well. And I think you guys have this same image in your PowerPoints of the optic glioma. Very much noticeable there. The ependymoma is next. Ependymomas are tumors that arise from the cells that line the ventricle. They can be cerebral or posterior fossa in location. Presenting symptoms and images often mimic a medulloblastoma, and you're going to want to star that statement. So, presenting symptoms and images of an ependymoma often mimic a medulloblastoma. And cerebral spinal fluid seeding is unusual, but it is far more likely in an infratentorial and anaplastic ependymoma. Treating an ependymoma, the goal is surgical removal with a gross total resection. Radiation therapy can be used for residual tumor or reoccurrence. Cranial spinal irradiation is going to be used if there is any cerebral spinal fluid seeding. A surgical bed in any gross residual tumor defined by MRI is going to be treated with a 1 centimeter margin around that area. Doses of 54 to 5940 are going to be commonly used. Chemotherapy has been used in investigational trials with high hopes to improve resectability of those tumors. Primitive neuroectodermal tumors, or PNETs, can occur anywhere in the brain of a child, although the most common place is in the posterior fossa. So when this PNET is found in the posterior fossa, it is going to be termed a medulloblastoma. The symptoms depend on their location in the brain, but typically a child is going to experience intracranial pressure. These tumors tend to be fast-growing and often malignant, with occasional spreading throughout the brain and spinal cord area. Epidemiology of medulloblastomas include now remember that they are a posterior fossa malignancy. It accounts for 20% of all childhood brain tumors. It occurs in children between ages around 2 and 12 years old, with a peak around 5 years. It arises from that pure primitive neuroepithelial cell, appearing as a small round blue cell. It has a high propensity to spread to and throughout the cerebral spinal fluid. Diagnosis and staging, headaches and early morning vomiting will occur intermittently at first and then become a more steady problem. Ataxia and cranial nerve abnormalities from invasion of the brainstem are common. Ataxia is lack of voluntary coordination of muscle movements. So you'll be thinking about gait abnormalities, those kind of things. Due to the high rate of the cerebrospinal fluid seeding, imaging studies such as MRI are used in order to visualize that entire CNS. Supratentorial and drop metastasis are present in about 25% of patients. There is a possibility for these tumors to spread metastatically, and that is usually to the bone. And you're going to want to remember that as well. They can spread to the bone. Staging of these tumors. Now, I know you guys talked about some staging in your slides, and I think you went a little further with what I have here, and that's great. But what, at the time that I had done this lecture, a modified version of the Chang system, staging system, was commonly used for staging. The original Chang system was devised in the late 60s before the use of CT and MRI. So we're relating the Chang system to tumor size, the invasion of the fourth ventricle and brainstem, and the amount of cerebrospinal fluid spread. So therapy is now based on residual tumor of greater than 1.5 centimeters and what extent of cerebrospinal fluid or gross neuroaxis metastasis is present. So treating medulloblastoma involves surgical removal of the tumor. It's done with a posterior occipital craniotomy. Chemotherapy has recently been added in randomized studies with about a 10 to 20% benefit. Now, looking at these children, when we do cranial spinal on these kids, we're going to need to add an anti-nausea medicine prior to treatment, because sometimes the exit dose going through the spinal fields can cause nausea. Think about how little these people are, and what kind of challenges they present with treating them, and this is one of them. I think I've showed you this slide before in our other brain tumor chapter, but here we have the medulloblastoma in the posterior fossa. We've talked before about how important it is to keep an eye on that incision for any areas that it may open up and leak cerebrospinal fluid. And I know you're going to remember the term for the meaning of when that incision would split open. So think about that now. It's always one of my challenging questions. The setup for these treatments are going to be with the patient prone in some sort of prone head holder. Their back is going to need to be very level, so it doesn't, we're not going to run into any sloping. Going to be positioned with some sort of head unit, making sure that, there's not a lot of skin rolls within that neck area. Here is just another, a more modern piece of equipment used for cranial spinal irradiation. Now, I know it shows an adult in this image, but remember, medulloblastomas are rare in the adult. So here I have a image of a cranial spinal setup. I'm going to widen that a little bit. When cranial spinal is treated, you're going to have the right and left lateral brains, and then a spine field will be added, a posterior spine field to encompass the whole spine, and then cranium here. So doses we're looking at are around 150 to 180 per day, to a total of around 3,600. After that, you may see patients have a posterior fossa boost once that cranial spinal field is finished, to bring that dose in the area of the posterior fossa up to around 5580. Some physicians have been known to reducing the craniospinal axis dose to 2340 because of late effects of radiation for those kids. So when I talk about a posterior fossa boost, we would be looking at, this area. So your field, it wouldn't be a whole brain boost. It would just be narrowed down right into that posterior fossa area. And at that time, the patient could be re-simulated supine. So they don't have to be on their stomach for that setup. So with these craniospinal treatments, it's going to be really important to monitor your patients for low blood counts, low nutritional diseases or needs, infection of any of that incision site, gastrointestinal issues, the nausea and vomiting that I talked about a few slides back. Eventually, the child's probably going to lose their hair from the radiation or the chemotherapy. And that's going to be something that will have to be taken into consideration because of the psychological effects that has on the child. And I think I may have had this slide in another PowerPoint as well, but this shows your beam entrances 3D on the treatment plan for the craniospinal. So you can see here, the beam is coming in at the lateral head. It's diverging. And when we're treating the posterior spine, often, as people grow, it's not going to be possible to do the entire spine in one field, so you have to split it into two. So this is where you would need to utilize the gap technique, because you don't want to have these two spine fields overlap, nor do you want the cranial field impinging on this posterior spine, in the neck area. So I just went back a slide here to look at this setup again. So you can see on this diagram how the gap is going to be needed between the upper spine field and the lower cranial field. You can see the divergence here and how that collimator here is actually rotated to match the divergence of that posterior spine field. And then a gap is used, so there's no overlap. We'll go over more of the craniospinal closely in more towards the summer when we start to talk about doing our competency for this field. Central nervous germ cell tumors are next. These tumors develop from embryologic nests of tissues in the midline of the supracellular or pineal region. The germinoma is the most common histology, and it happens to be very radiosensitive. It can be treated with low-dose craniospinal irradiation with a primary boost of around 5,000, or with chemotherapy and local field irradiation. Non-germinative germ cell tumors, but that's a mouthful, isn't it? Require chemotherapy, craniospinal irradiation, and a primary boost or primary tumor boost. The brainstem glioma is present with cranial nerve deficits that can affect vision, facial nerves, and swallowing. Most show up in the area of the pons and are entirely resectable. They tend to be high-grade astrocytomas. The treatment of choice is radiation therapy. And survival rate for these diffuse lesions is only about 10%. So even though we can treat them and get at them, their survival rate is pretty low. So benign tumors of the central nervous system include pituitary adenomas and craniopharyngiomas. Let me adjust my screen here a little bit so you can see that. Pituitary adenomas are going to occur most often in adolescents and young adults. They're going to be present with excessive hormone production. They'll have visual disturbances from pressure on that optic chiasm. Radiation therapy is pretty good at controlling these. It can control 70% of tumors. The craniopharyngioma arise from the embryonic remnants of the pharyngeal pouch. It disrupts the hypothalamic pituitary axis. It impairs vision or can induce seizures. Other benign tumors of the central nervous system include meningiomas and the acoustic neuroma. Histologically, these tumors are benign lesions that occur more often in patients that have neurofibromatosis. They're treated by observation if neurologic symptoms present, and then surgery. Radiation therapy is used for unresectable lesions. So late effects of treatment. Late effects of treatment are worse the younger the child is. So thinking of post-surgical deficits, these patients can have motor sensory loss, poor coordination, cranial nerve dysfunction. Survivors will see a decreased IQ by 10 to 20% for those high-grade gliomas and CSF spreading tumors. Hearing can be decreased with the use of cisplatin and radiation together. Craniospinal radiation can decrease the height of the vertebral bodies, leading to a short-waisted adults. There's a chance that hair loss can be permanent, and because of the younger age of these patients, there is a risk of second malignancies later in life. So retinoblastomas is another childhood tumor that we're going to talk about. Retinoblastomas are a primitive neuroectodermal tumor of the retina. It is the most common intraocular tumor in young children, but only occurs about 200 to 300 times per year in the United States. So it's very rare. They tend to show up in children ages 6 months to 4 years. 25 to 35% of patients present with a hereditary pattern, and the gene that is responsible for these retinoblastomas is known as the RB1 tumor suppressor gene, found on chromosome 13. This only happens, retinoblastoma will only happen when both alleles are hit. 65% of these cases tend to be unilateral without evidence of inheritance. Generally, as you guys talked about in your presentation, these tumors are discovered as a result of an abnormal retinal light reflex that shows up as white instead of red, and it may be noticed on a photograph or during the physician's routine exam. And that appearance of the differences in the eye color is called leukochorea. We cannot do biopsies of these tumors because of the risk for vitreous seeding. CT of the brain and orbit will detect any extraocular extension or the simultaneous supratentorial pineal lesion. Cerebrospinal fluid will be assessed with bone marrow biopsy. The staging system used is the Reese-Ellsworth staging system. That was done in the past, but it's now they look to the St. Jude system used, and you can find that somewhere around page 828. So that Reese-Ellsworth staging system, some doctors use that system to classify retinoblastomas that had not spread beyond the eye. So that system was helpful in determining the likelihood of preserving vision while still treating the tumor. Terms such as favorable, doubtful, and unfavorable are used in this staging system to refer to the likelihood that cancer can be treated while saving the affected eye, not whether the child will survive. So favorable, doubtful, unfavorable is related to saving the eye and not survival. 9 in 10 children with the intraocular retinoblastoma are cured. The major challenge is saving the vision in that affected eye. Here we have some images, and I know you guys used this in your presentation as well because I gave them to you. We have how that leukochorea presents with the use of when it's found on the picture of the young child. So when that tumor is present, it prevents light from the camera's flash from reaching the retina for processing. And that's why those eyes show up as white. So it's reflected out of the eye as a white glow or absence of the normal red reflex. So you've got the flash coming in here, doesn't reach the retina for processing, and is reflected back out of the eye and appearing on the photograph as a white glow. Here we have another image of that leukochorea appearance. A large retinoblastoma here, an eye that's been enucleated. This image is always interesting to me because you can see on examination, you're looking into that eye, you can actually see tumor here. Treatment technique for retinoblastomas include cryosurgery. Enucleation is used for extensive unilateral disease not involving the optic nerve, and it is almost always a guarantee for cure. Radiation therapy can be used in cases of bilateral or inoperable unilateral disease. Vision preservation can occur on the side with more advanced initial disease. Chemotherapy also has a good response. So we have some very distinct challenges when we treat these children with radiation therapy. So we want to be able to treat the retina and spare the cornea. So lateral and anterior fields will often be used with a divergent hanging lens block. A suction cup is used to displace the anterior globe so that we can get into that eye a little easier. 3D IMRT conformal volumes are used, or proton therapy is also a good choice. We're going to look at using 180 to 200 centigrade a day for a total of up to 4,000 to 5,000. Tumors that are less extensive can have treatments with implant plaques. So late effects of treatment for these tumors, the first one is cosmetics. Definitely are going to see this with radiation therapy because we can decrease the growth on one side of the face as opposed to how fast the other side grows. There's going to be effects on vision, high risk of second malignancy. Again, that facial growth impairment due to the higher doses of radiation that's used. Dry eyes and decreased tear gland function, and also cataracts. The thing about cataracts, if we treat the patient and they survive, the cataract can be removed. Neuroblastomas are our next pediatric solid tumor. I thought you guys had some really awesome pictures on your handout and your PowerPoint for this. So I'm going to head on through this section again. You should star this item here. Neuroblastoma is the second most common pediatric solid tumor. Brain tumors number 1, but the number 1 childhood cancer is leukemia. And the interesting thing about these neuroblastomas is that they have been found on autopsy in about 1% of infants. So there's some thought that these tumors spontaneously regress on their own. Neuroblastomas most commonly rise in and around the adrenal glands, which have similar origins to nerve cells and sit on top of the kidney. There are not many cases each year, only around 600. Maybe your guys' information said 650, just remember it's rare. Ages are from newborns to several years old. The median age is around younger than 24 months. And these tumors arise from primitive neural crest cells of the spinal ganglion, the dorsal spinal nerve roots, and the adrenal medulla. They tend to appear like small, round, blue cell tumor. They are derived from the neural crest origin, and most occur in the adrenal glands, like I said, followed by the abdomen and then the thorax area. A diagnosis and staging of neuroblastoma. These children tend to be lethargic, ill-appearing, younger than 3, with an abnormal mass, as tends to be common. They have that blueberry muffin sign that you guys talked about in your presentation. These are non-tender blue skin nodules. They appear most often when there's massive liver involvement. Bony, painful metastasis and bone marrow invasion can happen as well. 60% of these children present with symptoms of metastatic disease. So some of these metastatic symptoms include weight loss, abdominal distension from liver involvement, and lots of fatigue. Ultrasound, CT, and MRI are commonly used for diagnosis. If we're suspecting a paravertebral mass, MRI is good for that. CT is used for lung and liver masses. The classic appearance is calcification found in the mass shown on CT or radiographic images. You're going to want to star that. Bone marrow biopsy is required, and a bone scan will be done to look for any bone cortex lesions. Treating neuroblastoma. Remember, the tumor may spontaneously regress in the newborn, but it does have a progressive metastatic course in older children. Chemotherapy can be used. Surgery may cure resected localized disease without nodal metastasis. Radiation will play a role in patients with an incomplete resection. For stage 3 tumors, radiation with doses from 2,000 to 3,000 centigrade to the tumor bed may prove to be helpful. But low doses around 1,000 centigrade can help with pain relief or regression of soft tissue masses that will provide a short-term increase in quality of life. Late effects of neuroblastoma treatment include lung fibrosis, decrease or asymmetrical growth patterns in the child, and impaired function of the kidneys and liver. Wilms tumor, also known as a nephroblastoma, is a malignant embryonal cancer of the kidney. There are only around 500 cases annually in the United States. Median age is around 3 to 4 years. There's a percentage of cases that are bilateral. Now, I know, Samantha, you looked that percentage up recently, and that I think you said was 5 to 10% now. It is less common as children do grow older, and it's uncommon after ages 6 to 8, and it is very rare in adults, although there have been some cases that have been reported. It does have a slightly higher rate in African American children as compared to white, and is lowest among Asian American children. With Wilms tumor etiology, they look at what is known as the Weger syndrome. And this syndrome results from a deletion on chromosome 11. And it comes with birth defects and that deletion on chromosome P11P13. And the Weger stands for Wilms tumor, aniridia, which is complete or partial lack of the iris. The G is genital urinary tract abnormalities such as defects of the kidneys, urinary tract, the penis, the scrotum, the clitoris, testicles, or ovaries. And then the R is for mental retardation. Some other birth defects that they look at or that are included with that genital urinary tract are hemihypertrophy, which is an oversized arm or leg on one side, but the cryptorchidism, when the testes fail to descend to the scrotum, seems to be related to Wilms tumor, as does hypospadias. This is a defect on where the urinary opening is on the underside of the penis instead of where it is normally located. This video, I'll try to put this on the resource page so that you can see it. It's a good video that talks about the Weger syndrome. Diagnosis and staging of Wilms tumor. These tumors often appear as a painless abdominal mass noted on the pediatrician exam or when the parents bathe the child. Larger cancers can cause pain and pressure on the gastrointestinal tract, so discomfort there. Ultrasounds are used followed by CT for possible metastatic disease to the lymph nodes and lung. Direct liver invasion can mimic metastatic disease to the liver for tumors on the right side. 90% of these cases are of a favorable histology, which means there's no anaplastic or sarcomatous components. 15% are unfavorable, meaning they are anaplastic. They have a clear cell sarcoma or rhabdoid component in them. The unfavorable histology type tend to metastasize to the bone in the brain. And the staging system is based on operative findings, and then they relate the prognosis and direct the aggressiveness of treatment options at that point. So intraoperative examination of the opposite kidney does need to be done at the time of surgical due to the rate of bilateral disease. But removal of that malignant kidney is always the first step. Biopsy on the lymph nodes and tumor thrombi in the renal vein or inferior vena cava removed during surgery is also done. Large tumors are often soft and necrotic, which puts those tumors at risk for rupture and tumor spill in the abdominal cavity. And the tumor cell spill, if that would happen, affects prognosis. Treating Wilms tumor involves chemotherapy and radiation. This has been used preoperatively to reduce the tumor spill with a success rate of 32 to 40%. Radiation for completely removed stage 1 and 2 tumors is not necessary. Residual disease is treated to 1080 centigrade with a boost to the known area of residual disease of up to 2000 centigrade. Larger doses were used in the past, but they found through the studies that the late effects of the children were experiencing were too great to keep those higher doses. So that's when they lowered them down to around the 1080 to 2000 range. Treatment fields will cover the pre-op volume, the entire width of the vertebrae body, plus 1 to 2 centimeters contralaterally. And I want you to take a look at these DRRs, or these treatment field images, and just take note of how they appear. So you'll see on both of these setups, this is for an anterior-posterior field here. You've got the tumor bed where the kidney was removed from. You've got the entire vertebral body included across midline to about a centimeter and a half of that contralateral side. And that's going to prevent the child from having uneven growth in that spinal column. They may experience, short-wastedness, but they're not going to experience an uneven growth through that vertebral body area. Late effects such as scoliosis have been controlled by that technique of irradiating the entire vertebral body plus margin on that contralateral side and using lower doses. If thoracic radiation is needed for prepubertal females, breast development will be impaired. Lung doses are going to be kept below 1500 centigrade to prevent fibrosis when treating metastatic lung disease. Cure rates. With the addition of chemotherapy drugs such as vincristine and doxorubicin for advanced stage, cure rates have been reported up to be somewhere between 80 and 100%. Even patients with metastatic disease are being cured more than 70% of the time. So with the high rate of these overall cure rates, focus is being placed at reducing the late effects of treatment and to find more successful multidisciplinary methods for these patients with that advanced disease and unfavorable histology. And I know I mentioned to you guys that Katie Royston at the Cancer Center is a Wilms-Tumor survivor. She did have metastatic disease. She was, I believe, 8 years old when she started her treatment journey, and now she is alive and well and married with 2 children. So these cure rates reflect her disease path. Soft tissue sarcomas is not a topic that I had you guys talk about, and we'll just briefly take a look at these. Soft tissue sarcomas can arise from mesenchymal tissues occurring anywhere in the body. 75% of these cases are going to occur before age 10, and rhabdomyosarcomas make up more than 40% of cases. And the rhabdomyosarcomas occur in the head and neck, including the area of the orbit, the genital urinary region, extremities, and the trunk evenly. Diagnosis and staging. Symptoms are dependent on the area involved. So, if, for example, if tumor is in the orbit, the pain is going to occur in that area. If they are found in the extremity, the tumor may be painless. Staging of these rhabdomyosarcomas and other soft tissue sarcomas in the past was completed by the intergroup rhabdomyosarcoma study, and it has included the size of the tumor, resectability, nodal involvement, and metastasis. Generally, they're going to go metastasize to the lung and the bone marrow. The current system used is the TGNM. It also includes histology along with physical exam, size determination, and involvement of adjacent structures. Diagnosing and staging these soft tissues continued. MRI bone marrow biopsy and chest CT are all done to detect tumor size, involvement of the nearby structures, and metastatic disease. The first step in treatment of these tumors is complete removal of the mass. Radiation can improve local control and organ preservation in 90% of patients. Margins of treatment are 2 to 5 centimeters, depending on any nearby critical organs, knowing that growth plates must be shielded. The doses are going to be around 180 centigrade per day to a total dose of 3,600 to 5040. Chemotherapy is going to be used post-operatively and has led to higher survival rates. Late effects is going to be modality and location dependent. In the female, reproductive structures may be damaged. There could be dryness of the treated eye or retinal damage. Fertility is highly unlikely after chemotherapy and or radiation to that pelvic area. And amputations may be necessary for salvage treatment. Miscellaneous childhood tumors. Germ cell tumors. These germ cell tumors can occur anywhere the midline from the CNS through the mediastinum and retroperitoneum down to the ovaries and testicles. Most are benign and cured with surgery. Liver tumors, known as hepatoblastomas, occur in patients younger than 2. Radiation therapy is rarely used, so you guys will not see those. Leukemia, again, is the most common cancer in children, and it tends to be the acute lymphoblastic leukemia, or ALL. Extensive chemotherapy is needed. Radiation therapy can be used on the CNS or testicular area due to diminished penetration of the chemotherapy drugs in that area. These are actually called sanctuary sites. So the chemotherapy drugs actually don't reach those sites very well. So you may be called upon to treat a whole brain, what we call prophylactically, or the scrotal area. And that's pretty humiliating for those young people. Also, bone marrow transplant may be needed. Total body irradiation is often given as part of the bone marrow transplant. Miscellaneous childhood tumors continued. Histiocytosis X is a spectrum of diseases that involve abnormal proliferation of the histiocytic immune system Langerhans cell. We will often treat keloids and fibromas with low-dose radiation therapy when repeated resection and steroid injections fail. And that we're going to deal out doses of 900 to 1200 centigrade immediately following that resection for those keloids and fibromas. Keloids are what you'll probably see most often. So the patient would go in and have that keloid removed, and immediately following the resection, you would see them for their dose of radiation therapy. And that's usually delivered in one sitting with electrons, not photons, electrons. And then this video you can watch on your own. It's just a kind of just a childhood video that I want you to view. And that wraps up our chapter 37.